urgently randomized control trials. Please choose one.
Thank you very much. I really appreciate being invited, and it's a tremendous honor, and I'm really excited about being in Israel. So this meeting so far has been quite interesting, and as all the other speakers have learned, whenever you have a talk for 20 or 30 minutes, it's hard to figure out what to put in there, especially when you want to put on all these other parts. So I think I tried to limit it to just things that might not have been covered earlier, and hopefully there's not much duplication. These are my disclosures. So this was, at least the data from this study was shown in one of the earlier presentations, but probably not in this manner. So this was a study where the oncology treatment trial set out to show that this drug, ponatinib, was effective at treating CML. And actually the study was stopped early because it did meet its primary endpoint, and it had a significant improvement in the CML in patients that were given ponatinib. And this led to this information being released to the FDA in the United States, and the stock rose for the company dramatically in a span of a day. However, the next day, the release of the cardiovascular toxicities that occurred with this drug were similarly released. And so then the stock prices dropped by over 40% in a day. So I think that there could be many lessons learned from this particular study, but one of the most important ones is don't forget about cardiovascular issues, because no matter how effective your drug is, if there are important cardiac events, it could really do damage to the efficacy of the drug. So this is a prime example, and actually the FDA had to reverse their decision about the data in this particular drug within a 24-hour period. So it's really a unique example of how the toxicity seen by a drug could really have a tremendous impact on whether the drug is used. So let's just pick some other areas that we haven't really talked too much about so far. But when we look at anti-VEGF therapy or anti-vascular endothelial growth factor therapy, this has really been a focus of oncology treatment trials for really the last 15 years. And you can see on the left side of the screen are some of the tumors in which anti-VEGF therapy are used. At least in the United States, these are FDA-approved drugs for these particular cancers. And that's very important. It's very good that they have shown efficacy in these different cancers. But at the same time, on the right side of the page, you can see the impacts on the cardiovascular system. So that includes obviously the heart, and certainly these drugs are known to cause hypertension. But more importantly, if you look at the middle panel here, and you look at what's happening in the small vessels, that over the course of time with anti-VEGF based therapy, the capillaries and small arterioles involute and ultimately become non-functional, a process that's referred to as anatomic rarefaction. And then further, if you look at the kidney structures, the glomerulus has a tremendous number of capillaries, and the same sort of process can happen in the kidney tissue. So for each important effect of a cancer therapy, there is obviously an important effect on the cardiovascular tissue. And then, you say, well, okay, fine, there's just one drug out there that I got to worry about. There's one anti-VEGF based therapy. Well, unfortunately, that's definitely not the case. And this is the list from, actually, it's about a year and a half ago, of all the drugs that were approved by the FDA for the treatment of some sort of cancer, that predominantly their main action is anti-VEGF based therapy. Now, I probably need to update this slide, but certainly there are at least double this number of drugs in development in oncology treatment trials that have the same basic action. So, it's not like you can just say there's one drug that's potentially going to cause a problem. There's already 10 and there's 20 more on the way, and the acceleration of drug development on the oncology side is really quite impressive. So, whatever list exists right now, you have to be ready to modify that. And so then when we think about ways in which we can provide cardioprotection, there's certainly theoretical ways, and then there's actual ways. This is just a figure kind of describing some of the methods in which we might be able to enhance cardiovascular protection for patients that are being treated with anti-VEGF based therapy. So, it can include something, I'm not sure I even know what AMP kinase inhibition or energy compromise is, I suppose I know what pro-apoptotic effect is, but, I certainly know, that if we increase LV afterload in a cardiovascular system, that's a very negative thing and something that we don't want to do on a chronic basis for sure. And then thinking about what strategies there are to potentially provide protection include basic strategies that we're very comfortable with, such as beta blockers and ACE inhibitors. But then, some of these other potential therapies, need to be explored. They're not clinically relevant at this point. So I think that, we need to think about what is known and then certainly what is not known and how can we apply that most readily in our patients. And so to just take this down to sort of, the nuts and bolts of things, one of the things that we know very well is for anti-VEGF based therapy, especially in renal cell cancer, that this is one of the cancers that has been very responsive to anti-VEGF based therapy. And it was a key treatment because those cancers, or renal cell cancer in particular, was very refractory to any treatment that we had collectively had been giving them. And to find effective therapies was critically important. But of course, the main side effect or the main effect of those therapies was substantial hypertension. So I think that, we've had to figure out how to manage that hypertension more effectively. But one of the key points that we've sort of learned by looking at things retrospectively is that it does matter which therapy you use. So it does matter which antihypertensive therapy you want to pick. And so understanding how we can be more careful or more disciplined in our picking of blood pressure medicines is a key point. So I think that if you look here at this retrospective study, it just showed that for those, this is the most curious abbreviation for renin-angiotensin system inhibitors that I've ever seen. So it's the red line, the ASI, and I think it was angiotensin system inhibitor or something. So that's the group of patients that were on RAS inhibitors, and you can see that their overall outcome was much better if they were on that class of drugs. And in a way, that's contrary to what you might normally do in those patients, because most of them had some degree of renal insufficiency. Probably the majority had at least one kidney taken out. And to use that type of therapy maybe kind of go against what you would normally do. And so I think it's important for us to really pay attention to what's going on and constantly look back. And then in the future, as I'll sort of show, we really need to look at prospectively what we've learned retrospectively. So, and then to add a little bit more to that, just the idea of a statin in those same patient population, the statin had a very profound effect on overall survival of those patients. So I think everything else taken the same, If they were on a statin, they live longer than if they weren't. So I think that this is a very important retrospective observation, and then it leads to the hopefully prospectively proving these points. So one of the things that's also really important is, you don't, as was talked about several times this morning, we don't necessarily want to have any particular recipes, especially if the recipe's not all that good. If the recipe doesn't make a very good cake, then don't make that cake, or, find a different recipe. So I think that if we start making a bunch of recipes and we don't verify that those recipes are helpful, then we're not advancing the field. But this is one such recipe, and actually I don't have a major objection to anything here, although there are certainly things that I might change myself. But just the idea that for patients that are undergoing anti-VEGF based therapy, you would have the patient make sure their blood pressure is monitored at home, but on every clinic visit, you may use specific cardiac tests to help guide your choices. And then you obviously want to screen for heart failure at every visit. This is a very practical approach that I do agree with. And then I think it's more about that interaction to help guide the treatments in those patients. It's not so much about how often we do a particular test or how we interpret those test readings. It's more about contributing to the care of that patient as it's ongoing. So let's take another look at, this particular data was shown on one slide this morning, but you probably wouldn't have seen it because it was buried in other parts of the slide. But this is just a perfect example of what I would say. It's very important to understand how do we interact with the patients and the providers at the moment of cancer therapy. So, for example, this is a huge breast cancer study and showed just a tremendous benefit for combination therapy for breast cancer. And in particular, if you look at the blue box, that is the major difference that was made by having anthracycline, Cytoxan, Taxol, and trastuzumab given to patients that had significant breast cancer, HER2-positive breast cancer. And you just look at that blue box and you see that the amount of breast cancer recurrence was dramatically reduced by those people that got what I like to refer to as the kitchen sink. They got everything. They got it all. And it made a huge difference in breast cancer. And then you say, well, a little bit of heart failure among friends is okay, especially if they're around to live. So I would argue that point quite differently because, for example, if you look at this table, which is also in that same publication, you look at the rate of congestive heart failure was only 2%. But I would say this is grade 3 or 4 heart failure, and that is heart failure at rest. That is not the kind of heart failure we like, and we certainly would want to try to avoid that if at all possible. And then you say, well, what about all this monitoring that was done as part of this trial? Yeah, there was a lot of monitoring. They did a lot of EF measurements. And, if you look at the amount of people that had significant change in their ejection fraction, it was 1 in 5. So was that change in ejection fraction our telltale mark for the development of heart failure? Was it our one chance to catch it before it developed? And, I would argue differently that, the change in EF may not be that important, but what it's telling you is critically important. And then what's even more important than all of that is the question, is it enough to just detect it? We don't want to detect it. There's this commercial that is on TV in the United States, at least, where that one security company is sort of advertising, their benefit compared to some other security company. And they show this little scene where there's a security guard in the bank, and a bunch of robbers come in and they hold everybody up. And the guy that was the security monitor stands up and raises his hand. And, one of the people that were on the floor now, because the guns were being pointed at him, said, "Aren't you going to do anything?" And the monitor goes, "No. So my job is to monitor, is to show that there's a break-in. I'm not going to do anything about it. I'm just going to show there's a break-in." So I would say that's what this is. We are showing that there's a break-in, but there's no discussion about what was done about it. Was there any ACE inhibitor or other heart failure therapy given at this point? And, that's never been published from this study, and I'm sure it won't be, but that's the critical point. It's not whether there's a break-in, it's what are you going to do about it? And so I think that this is a nice publication from our colleagues in Italy, and I think it's really gives you sort of a true answer of this is what you do about it. This is how you do it right. And if you, for example, look at this group here, they got combination therapy for their LV dysfunction, that 100% of them had full improvement of their LV function back to normal. So that's what you do about it. You treat them optimally for the heart failure, for the LV dysfunction that you found. And, this is not just saying that there's a problem. It's like, how do you manage this? And then there was some discussion earlier about echoes and MUGAs, and I really had to keep my mouth shut because it's very hard for me not to have an opinion on it. But this is a nice study just showing that, there is a reason why one might be better than the other. And you could argue about whether one test is more reproducible than another, or how easy it is, or how expensive it is. Whatever. You can argue those things forever. But this study actually really emphasized, it's like, what are you going to do about the abnormality? It's not which test you did, it's what happened after that. And if an echo was done in this particular study, the patients were much more likely to have a cardiologist engaged, and they were going to be more likely to be on appropriate heart failure therapies. So the key point is not whether you monitor it more accurately, but what's the next step? What are you doing to prevent it from getting worse or treating it in its optimal fashion? And so then again, most of these studies were retrospective. And this will be kind of the final retrospective study that I'll show. But it's particularly important in that, it showed that a statin prevented the development of heart failure. And you go, well, how did that happen? What is a statin going to do about prevention of LV dysfunction? And, I can propose numerous possibilities, but the facts are that in the group that was on statins and they were undergoing anthracycline and trastuzumab-based therapy for breast cancer, that they had a better long-term outcome than those that weren't on statins. So I think that it's an important point that optimal cardiovascular care does have an important impact. So, do we have any randomized studies to guide our practice to date? So this is an interesting question. So let's take a look at a few. So one of the first was a study looking at people that were, again, this was from our Italian friends, that were looking at patients that were getting high-dose chemotherapy. Most of it was for breast cancer, but there were other cancers as well. And they were getting multiple drugs, including anthracyclines. And they randomized them to either an ACE inhibitor or a placebo. And you can see the group that got an ACE inhibitor had virtually no cardiac events compared to the group that had placebo. And you can see there's a substantial number of real cardiac events, not just EF changes. So I think that the addition of an ACE inhibitor to this picture was helpful, no question. It was a small study. The total number of patients was under 100. Then there was a similar study done predominantly with anthracycline-based treatment, and they looked at carvedilol, whether carvedilol prevented the development of LV dysfunction. And the group that got carvedilol had no change in EF, whereas the group that had placebo, you can see there was a significant drop. Now, this is also a very well done study, but it was still small. Probably total number of patients, I think, was around 70 or so. So again, we're not talking about major cardiology, typical randomized studies with thousands of patients. These are very small studies, but certainly apply an important principle. And then this study, whenever I talk about this one, it's just really impressive to me that they actually did it. So I always give them kudos for that. But basically, they randomized patients that were either getting multiple drug chemotherapy for leukemia or they had lymphoma and were going to get a stem cell transplant. So they're going to be admitted for many days, have multiple drugs. Very high risk, high stressful situation, obviously, for those patients. And they randomized them to carvedilol and enalapril versus placebo. And so for anybody who takes care of those patients, just having a patient get 2 blood pressure drugs when they're about to get 6 or 7 other chemotherapy drugs, that's impressive how you could do that. And talking to the PI of this study, he said, I had to go up to the nurse's station every day and beg them to give the medicine. And, I can see that. I can see that happening because, they're just not going to do it. But they did do this study. It was only in 91 patients, but in the group that got the combination therapy, you can see there's no change in ejection fraction. And then there's far fewer major cardiac events, even in a small population that was very sick, very high risk. So, the point that these drugs could be helpful in high-risk patients, I think they definitely made that point. So then let's look at some other studies that were recently reported. So one was the PRADA study, which looked at breast cancer patients, and they followed them with periodic MRIs. And so, this was probably our best measurements of ejection fraction that could be done in a serial manner with patients because, most people will say that the MRI is probably the most specific in terms of EF measurement, which is all well and good, except for most people can't get serial MRIs. But in this particular study, the thing that they did is they randomized the patients to either candesartan or metoprolol, the combination, or placebo. And total number of patients was about, I think it was about 100, a little more than 100. And the one thing that we found is that candesartan was modestly protective. However, metoprolol was not. As you can see here, metoprolol was not protective in any particular subgroup. And in a way, this makes perfect sense because, if we look at heart failure trials, in asymptomatic people with minimal or normal EF, minimal reduction in EF or normal EF, then it's actually an ACE inhibitor that prevents the development of heart failure and not metoprolol or other beta blockers. So this is exactly in line with what we know of in the heart failure world. So at least I don't use candesartan a lot, but in Europe, I understand it's used more frequently. So I think, can candesartan be applied to all of our prevention studies? I think there is some clear evidence in a very carefully done study that it is helpful. There was a similar study done, the Manticore study in Canada, that randomized patients to perindopril, which is also an ACE inhibitor that I don't use, bisoprolol, or placebo. And this was primarily with trastuzumab-based therapy. So one argument about this study is that they weren't really doing very high-risk patients. They were only getting trastuzumab. small percentage got anthracyclines. And I think that most people would say trastuzumab is not as risky a therapy. In any case, what they found is that there was no major difference between the ACE inhibitor, the beta blocker, or placebo in this particular study in terms of changes in volume, which is what the primary endpoint of the study was. There was, however, a somewhat of an attenuation of subsequent LV dysfunction with bisoprolol in this particular study, so that in this case, bisoprolol may be partially protective. But the one thing about this particular study is it wasn't a large number of patients, and also you could say that perhaps they weren't really high risk. They were lower risk in terms of cardiac risk, at least. And then this is just a summary slide looking at drugs that may have a prophylactic effect, and it also summarizes whether it was a randomized controlled trial or retrospective. So certainly there's some evidence that these trials are pointing us in the right direction, and that can we find strategies that will be more cardioprotective. But clearly we need to have larger numbers of patients and have more important additional cardiac endpoints that we're looking at. So this is a very interesting study, also reported from our Italian group, just looking at what strategy would prevent atrial fibrillation in patients that are undergoing lung cancer surgery. And I think that for any of you who work in a hospital where they do a lot of lung cancer surgery, then I'm sure that you know that AFib is your most common consult. So coming up with a strategy to minimize that makes perfect sense. So I think that this is a good example of an important clinical trial looking at a very common event and what strategy can we use to prevent that or to improve it. So they randomized patients to either prophylactic metoprolol, losartan, or control. And they utilized N-terminal pro-BNP, or a natriuretic peptide, as a way of stratifying the risk of those patients. And so the findings are really quite interesting. If you look at overall, the rate of atrial fibrillation in this population was 9%, so that's pretty high. But then if you look at those, the rate of atrial fibrillation in those that had a high N-terminal pro-BNP before surgery, it was 20%. So you could use typical cardiology information to stratify those at highest risk. So I think that it's this type of study that we really need to be doing in cardio-oncology. We don't need to be trying to reconstitute, retrospective studies. We need to figure out what things we can do that will help guide our practice going forward. And then more importantly, if you look at, the development of atrial fibrillation, especially with either metoprolol or losartan versus control, you can see a dramatic reduction using either metoprolol or losartan compared to control group. And if they had a high BNP or N-terminal pro-BNP, you can see that the amount of reduction was even more impressive. So I think that using typical cardiology strategies to manage these problems could have a dramatic effect. So just to summarize kind of what we know, at least in a randomized fashion so far, is that cardiotoxicity can be prevented. And so, the term cardiotoxicity encompasses more than just LV dysfunction. So it has to encompass thrombosis and atrial fibrillation and other vascular problems, as have been pointed out in our earlier lectures. But in terms of which drugs do we want to think about, and depending on your practice environment, they may be available and maybe not. I don't know about nebivolol in Israel, but certainly carvedilol is widely available in the US. ACEs and ARBs, we've got tons of them to pick from, and I don't know which one is more common in your area, but clearly these are effective drugs for prevention. And then you could argue that in high-risk patients, the combination was shown, and certainly spironolactone and statins, there are certainly evidence that they could be helpful. So let's think about the span of inhibitors for cancer therapy is very broad. So I'm just going to show you a couple of others that are out there. So, and why they would be concerning for cardiovascular events. So the proteasome, for example, is a very active system in the myocardial tissues, and for a normal cardiac structure, you need to have a balanced amount of synthesis and degradation of protein in your body. So that's normal. And then disturbances in that balance could result in serious cardiac events, of course, or problems. Well, the proteasome inhibitors are at this point are cornerstone therapies for myeloma. And there are numerous ones being developed, but there are two that are, there's 3 IV and 1 oral that are currently in the market that I'm aware of. But the key thing is that some of the newer proteasome inhibitors are irreversible inhibitors of the proteasome. So if you go back to the slide about the myocardium, if you were a myocardial cell and you were now given an irreversible inhibitor of the proteasome, that might be a problem. So here's an example of a patient that got a proteasome inhibitor, carfilzomib in particular, and after the 4th dose, developed ST elevation and acute coronary syndrome. Didn't have a big infarct by troponin as measurements, but the EF dropped to less than 20. Once they were, and then had no evidence of coronary disease. And you can also see a very prolonged QT interval in this case. And then after a month later, the EF normalized with appropriate treatment, but you look, the QT interval is still markedly prolonged. And then we reported on our experience with some of the serious cardiac events that occurred in these types of patients. And the range is not simply LV dysfunction. It includes right-sided heart failure. It includes heart failure with a normal EF, acute coronary syndromes, QT prolongation. So the range of problems is much broader than the classic anthracycline EF changing over time type pattern that we've been thinking about. So we need to think differently. And then one of the more important phase 3 studies of carfilzomib, just recently, the ASPIRE trial. If you look at the total number of cardiac events in the group that got carfilzomib, you can see it's higher than placebo. So more than 25% of the patients had serious cardiac events. If you add dyspnea to that, it's almost 50% of the patients. And then if we just look at the rate of DVT-PE in these patients, it was twice as high in the group that got carfilzomib. So combination therapy with an IMiD and a proteasome inhibitor. So, the whole cardiovascular toxicity picture has to include thrombosis, which, we had a very nice lecture earlier about that idea. And then, strategies for minimizing thrombosis are, unfortunately, there is no randomized control study that's going to give you any guide. This is all basically retrospective, and it's just like, well, this is what we do in practice kind of thing. But this is the current recommendations, but I would say there's nothing there that's prospective and tells you this strategy is better than this strategy. And then was also mentioned earlier, especially in breast cancer patients, if you were to start adding immune therapy to that crowd, I would say you're asking for some serious trouble because they've already had, some of them or most of them have had anthracyclines, and probably some or most have gotten trastuzumab. And then if you add another potentially cardiotoxic therapy to that mix, you're going to run into problems. This is just a report of but these therapies are critically important. So, for example, in melanoma and lung cancer, you're finally seeing a huge change in the outcomes of these patients with immune therapy. But no doubt there are cardiac issues. And this is just a report of myocarditis that occurred with immune checkpoint inhibitors, especially combination immune checkpoint inhibitors. And I think that, we need to figure out how to identify those patients earlier, because most of the reports right now, those patients have died from this problem. So I think that we certainly want to catch it earlier. And some of you may have seen this slide before, but it's always helpful for me, because when I start talking to oncologists and they start going on and on about kinase inhibitors, I get lost. And I like this one because I got it, I understand it. So if you look up the NCI website, you'll see this description. It says a kinase inhibitor is a drug that interferes with cell communication and growth and is sometimes used to treat cancer. Now, I really like that, but most importantly, I would say any medication that inhibits cell communication and growth. You could imagine that your cardiovascular tissues could be unhappy with that. So this was also mentioned earlier, that there's some guidelines out there. I would say that you have to be a little bit careful about the word guidelines, because it's interesting, this is not a guideline, it is a position statement. However, they sent out pocket guidelines, and then there's also a smartphone app, which I'm not sure what they're calling that, if they're calling that a guideline or what, but so there's a lot of mixing of terms, but this is a position statement because we don't have a lot of class 1 evidence to say do this versus that. So that's where we really need prospective studies to have a guideline. And we saw this slide earlier. I will only emphasize this slide in that I think it's a great summary of what is known about testing in the cardiac safety realm. And it talks about advantages and disadvantages. I think it's a very nice table summarizing a lot of complex stuff. And then what I would say is that there is an ASCO guideline for cancer survivorship, and this is a true guideline because we looked at all of the randomized data, et cetera. But you'll also note, if you actually ever read these guidelines, that there are several places where we made no comment because we couldn't. Everything else would have been just our opinion. So, but I do think that it is extremely important that ASCO supported this, and it actually is a guideline, much to the standard of any other guideline that you may have had. And then I'd just like to close by saying this was a recent publication in the International Journal of Cardiology. I find it to be really fascinating. And the thing that's so important about this is it really is telling us what the current picture is. So in a survey of 300 and some odd French oncologists, they were asked about many things about cardio-oncology. And so they did frequently check an echo, or I'm sorry, they would frequently check an ejection fraction measurement before anthracycline or trastuzumab, but they wouldn't with VSP inhibitors, which are like VEGF inhibitors, or any other drug. There was much less frequently that they would monitor ejection fraction. Well, you'd say, okay, I understand that. But then look at the amount that do EF measurements during anthracycline. So anybody would say anthracyclines are worse than trastuzumab, and then we're only measuring EF half the time during therapy, whereas in trastuzumab, you're monitoring it all the time. So, how important is that? And then for other therapies, it's not monitored much at all. And then after therapy, look at the rate of EF measurements. So this is what the oncologists are actually doing. And I think that that's really, really key, because we can all argue about the things that we want to do, but what's actually happening out in the world is where we need to change practice. And then this slide summarizes a lot of things about that survey, but what I would point you to is just, they were asking about actual practice decisions based on EF changes and, what to do. And you can see there's a lot of variation in the answers. And I think that's because the oncologists don't really know, what we recommend because we don't know. So I think that this really sort of sets the tone for where we need to go. So what data do we need to be confident of our recommendations? So we really need to have disciplined reporting of clinical observations is absolutely imperative. So if you have a trial like that one that I showed at the beginning for ponatinib, they just said that there were an intolerant amount of vascular events, but they didn't tell us what those vascular events were. We need to know the details of it to be able to have an adequate action plan. So I think that we need to improve our trial reporting so that we understand what's the best way to deal with it. And then we need to keep our mind open to new observations. So just like with checkpoint inhibitors, myocarditis is a rare but probably fatal event. We need to put our good thoughts together to figure out how do we identify those patients before they develop that problem, because once it gets there, we can't do much about it. And then really as a general goal for cardio-oncology, we absolutely have to commit to collective research in the field. This has been said several times today, and I couldn't agree with that more. And then in terms of just what do we need to do in the future, this is what I like to think of as our marching orders. And certainly we need to define how to detect cardiovascular toxicity. We need to describe the best clinical approaches. We don't need to just say, I'm monitoring something. No, we need to say, well, what are you going to do about it? How are you going to manage it better? And then we really need to commit to training and education really at all levels. That includes, of course, our trainees, but it includes all of us in practice too. And I think that we need to understand how to refine our knowledge base. So all I will say is that the world of cardio-oncology is broad. This is a nice figure from a very nice paper by my very close colleague. And I would encourage you to look at it and think about this figure. And just some of the ways in which cardiovascular toxicity is manifest are quite diverse. And then our strategies for prevention or mitigation, should include all of these things: awareness, exercise, diet, etc. So we have multiple strategies for a problem. And then I would encourage you to come to our Global Cardio-Oncology Summit in September. Thank you.
Thank you so much.